Okay, hi everyone. My name is Jasmine Delijani.
I'm Lindsay Helm.
I'm Rachel Jackson.
I'm Reyna Moreno.
This is our video on postpartum hemorrhage. So this case study is an exploration of the pathophysiology and outcome of a patient with postpartum hemorrhage due to perineal lacerations. In the United States, the most common cause of severe and preventable maternal morbidity and mortality is postpartum hemorrhage. So you can see this is a graph of the rate of postpartum hemorrhage increasing over time. So for our case study background, the patient is a 28-year-old female, estimated gestational age of 38 weeks and 5 days. Before delivery, she was a G1, T0, P0, A0, L0, and after delivery, G1, T1, P0, A0, L1. She has no significant med-surg history, no significant pregnancy-related problems, and no known allergies. For the prenatal labs, she's immune to rubella, HIV negative, Hep B negative, GBS negative, syphilis negative, and chlamydia negative, and blood type is O positive. She had spontaneous rupture of membranes at home and then presented to the labor and delivery unit with regular uterine contractions every 5 to 10 minutes, and she was 1 centimeter dilated, 70% effaced, and at -2 station. Her husband was present. She was given Cytotec for cervical ripening and an epidural for pain control, and continuous external monitoring was started. She had a vaginal delivery with compound left-hand vertex presentation. Apgars were 9 and 9, birth weight 6 pounds 14 ounces. Placenta separated with gentle traction and was intact after being expelled. However, the patient sustained second-degree perineal lacerations extending to the labia bilaterally. This led to a 700 milliliter blood loss, so our high-risk diagnosis is postpartum hemorrhage. For the Newman Systems model, the physiologic variables include the pain of delivery and the blood loss leading to hypotension and dizziness. Psychological variables are the stress and anxiety of delivery, supportive individual for emotional support being present, such as husband or mom, and the fatigue and dizziness leading to impaired ability to bond with the infant. Developmental variables are this is the couple's first child, so they have some anxiety and uncertainty about newborn care. Sociocultural variables are the importance of family presence, and there are no particular spiritual variables identified.
Let's look into the pathophysiology of postpartum hemorrhage. So PPH is a blood loss greater than 500 mL after vaginal birth or greater than 1,000 mL after C-section. It can happen due to urine atony or bladder distension. It can be due to retained placental fragments or clots in the uterus, trauma such as lacerations, uterine rupture, uterine inversion, or it can be also due to coagulopathies. How is it treated? So uterine atony, we will treat this by performing fundal massage or emptying the bladder to stimulate the uterus. We can actually manually remove any fragments stimulating the uterus. For the trauma, we will suture the lacerations, and to treat the coagulopathy or underlying disorder with glucocorticoids, immunoglobulins, and platelet transfusions. There are 3 stages of postpartum hemorrhage. Stage 1 refers to a blood loss greater than 500 mL vaginal or greater than 1,000 mL cesarean. The vital signs may be normal or increased heart rate and decreased blood pressure may occur. Stage 2 refers to continued bleeding with a blood loss less than 1,500 mL. Stage 3 refers to a blood loss greater than 1,500 mL or in which more than 2 units of packed red blood cells are administered and stable vital signs. Complications of untreated PPH can lead to hypovolemic shock, thrombosis, acute respiratory distress, organ failure, sepsis, anemia. The patient can go into ICU, and there is a high risk of mortality. So what is a second-degree perineal laceration? It extends through the perineal skin to the perineal muscle. So risk factors for this are first vaginal delivery, delivery of long gestational age infant, malposition infant, forceps or vacuum-assisted delivery, if the mom is older than 25, poor nutrition, and labor induction. Complications are hemorrhage, stress, pain, infection, and fecal or urinary incontinence. Treatment of perineal lacerations. Rapid assessment for any lacerations in the perineal area. It is important to stabilize the patient's hemodynamic status with IV fluids. such as giving 2,500 ml bolus LRs and surgical repair of the lacerations with sutures. Applying pressure to the bleeding area and packing may be necessary. Let's talk about the mom's vital signs. So the heart rate was 124 BPM, respirations were 20, temperature 36.5. The blood pressure before the bleeding was 110/70. While bleeding, the blood pressure dropped to 77/55 milligrams of mercury. The O2 sat was normal above 95. The hemoglobin was 12.8, hematocrit 37.3, platelets 157, red blood cells 3.7. The level of consciousness, so the patient started feeling dizzy, so fluid bolus of 2.5 L, lactated ringers was given, and assessed in the fundus, it remained firm throughout. And level of attachment, skin-to-skin care was initiated, but mom was so dizzy and fatigued that breastfeeding wasn't able to begin at first.
So nursing diagnosis and goal for mom. The nursing diagnosis is deficient fluid volume related to loss of blood secondary to perinatal lacerations, as evidenced by estimated blood loss of 700 milliliters during vaginal delivery, patient statement of feeling dizzy, and blood pressure dropping to 75/55 millimeters of mercury. The goal is patient will demonstrate normalized fluid volume status by 1, maintaining blood pressure of at least 110/70, and 2, stating the dizziness has resolved before transfer to postpartum unit. Nursing interventions for the mom. Intervention number 1, monitor blood pressure, pulse, and oxygen saturation continuously while bleeding is occurring in the 3rd and 4th stages of labor, and assess for symptoms of hypovolemia, such as tachycardia, hypotension, and dizziness. Rationale: the earliest sign of postpartum hemorrhage in terms of vital signs may be tachycardia, and it is necessary to monitor for other symptoms so that interventions may be immediately completed. Intervention number 2, hydrate the patient with oral replacement therapy and isotonic IV solutions per physician's orders. Rationale: patients with hemorrhage should have fluid replacement with normal saline or other crystalloid solutions via IV access. Intervention number 3, lower the head of the bed to place the patient in a supine position to prevent dizziness. Rationale: the patient should be kept in a flat position to prevent dizziness from hypovolemia, and the patient's legs may also be elevated if necessary. So the outcome was the goal was met. The patient demonstrated normalized fluid volume status as evidenced by maintaining blood pressure over 110/70 and verbalizing the dizziness was resolved before transfer to postpartum unit. The nurse also lowered the head of the bed. Approximately 2,500 milliliters of IV bolus of LR solution was administered. Juice was also given by mouth. The physician sutured the lacerations and held pressure on the perineal area as well. The patient's blood pressure rose to 114/75 and did not drop back down. The patient's oxygen saturation was stable at 95 to 100%. The patient stated the dizziness was lessened about 15 minutes after receiving the IV bolus and drinking the juice.
Okay, so for the nursing diagnosis and goal for the baby, nursing diagnosis is risk for impaired parent-infant attachment related to dizziness and fatigue secondary to postpartum hemorrhage. The goal was to have the family unit be free of impaired parent-infant attachment as evidenced by 1, demonstrating behaviors that indicate secure attachment to the infant, such as cuddling, cooing, talking, looking at baby, and 2, provide a nurturing environment sensitive to infant need for nutrition, feeding, sleeping, comfort, and social play, swaddling, breastfeeding, hunger cues, and all of this prior to transfer to the postpartum unit. So the interventions for baby, intervention number 1, encourage initiation of early breastfeeding and provide support. Rationale: breastfeeding is an important aspect of parent-child attachment as it is a parenting behavior that is connected with the child's emotional development later in life. Intervention number 2, encourage physical closeness using skin-to-skin experiences as appropriate. Rationale: kangaroo care is essential in promoting the connection, support, and bonding between mothers and their babies. So the last intervention is to educate the mother and family to identify strategies that provide a nurturing and supportive environment for the infant, such as keeping the room quiet and undisturbed to facilitate sleeping, maintaining a neutral thermal environment between 72 degrees 72 to 76 degrees Fahrenheit and swaddling for comfort. The rationale for this is that newborns are quite vulnerable to extreme temperatures and lose heat easily because of their thin skin, a large body surface area, low subcutaneous fat stores, and lack of the ability to shiver. A neutral thermal environment is critical in order for newborns to conserve energy for growth and development. So the outcome for the baby, the goal is met. The family unit remained free of impaired parent-infant attachment, as evidenced by the ability to demonstrate attachment behaviors and ability to provide a nurturing environment before being transferred to postpartum unit. While the mom was dizzy, the father was making sure the baby was securely placed in skin-to-skin contact. After about 20 to 30 minutes, the mom stopped feeling dizzy and became more alert so she could begin attachment behaviors, such as smiling at the baby, cuddling, and talking to the baby. The mom was able to swaddle the baby and successfully breastfed about an hour after delivery. The father also spent time holding and cuddling the infant. In conclusion, by providing evidence-based quality care to a patient at risk for postpartum hemorrhage, both the mom and baby had positive health outcomes. It is imperative for a labor and delivery nurse to be able to properly assess a critical patient, analyze for symptoms of hemorrhage, and then develop an appropriate evidence-based plan of care to promote best health outcomes. Understanding the dynamics of medical and nursing management of this physiological condition allows a nurse to greatly reduce the chance of morbidity and mortality of mothers at risk for postpartum hemorrhage. And these are our references. Thank you for watching.